Dr. Arion. Senior Health Education.
You are about to hear something that most doctors will never say out loud. And before this video is over, you are going to understand exactly why. I am not going to sugarcoat it. I am not going to wrap it in medical jargon and hope you don't notice. Because what is happening inside hospitals across this country right now today is something that every senior and every family member of a senior needs to know about before they ever walk into a surgeon's office and pick up a pen. So I want you to stop whatever you are doing. Put the phone down on a flat surface. Get comfortable, because the next few minutes could be the most important thing you watch all year. Not because I want to scare you, but because you deserve the truth. And the truth, as it turns out, is something nobody has been giving you. Here's what I can tell you right now, before we go any further. There are 5 surgeries being performed on seniors all across America every single week. 5 procedures that are being recommended, scheduled, and signed off on. And in a significant number of cases, those surgeries do not save the patient. They end them. Not the disease, not the age, the surgery itself. The very thing that was supposed to fix the problem becomes the thing that causes the final one. My name is Dr. Arion, and I have spent decades in the field of medicine working alongside surgeons, cardiologists, oncologists, and geriatric specialists. I have sat in rooms where these decisions were made. I have reviewed cases. I have watched families sign consent forms without understanding what those forms actually meant. And I created this channel, Senior Health Education, for exactly this reason, to give you the information that the appointment does not. To give you the time, the clarity, and the honest picture that a 15-minute consultation rarely provides. If this is your first time here, I want to ask you something right now. Before we go any deeper, if this kind of information matters to you, if you believe that seniors deserve real answers and not just reassuring nods, then hit that subscribe button right now and give this video a like. It takes 2 seconds and it tells us to keep making content exactly like this. It also helps other seniors and other families find this channel before they need it most. Okay, now, let us get into it. Let me paint a picture for you. Imagine someone you love. Maybe it is your mother, maybe it is your father, your spouse, your neighbor who has lived next door for 30 years. They go to the doctor for something that has been bothering them for a while. Back pain, a blocked artery, a mass on a scan. The doctor does some tests, looks at the results, and then sits down across from them and says, "I think we need to talk about surgery." And just like that, a clock starts ticking. The paperwork gets organized, the scheduler calls, and the person sitting in that chair, the person you love, starts nodding along because this is a doctor. Doctors know best. The hospital has the equipment. The insurance will cover most of it. Just sign here. And nobody, not one person in that room, says the thing that should always be said first. Nobody asks what happens if we do not operate. Nobody asks whether there is a less invasive option. Nobody explains what the recovery will actually look like for a body that has been living in this world for 70, 75, or 80 years. And that silence, that gap between what the patient hears and what the patient needs to know, that is where the real danger lives. I want to be completely clear about something before we go any further because I know how this can sound. Surgery saves lives. I believe that. I have seen it happen. A well-timed, well-matched surgical intervention can be the difference between years of life and weeks of life. For the right patient, with the right profile, in the right hands, surgery is an extraordinary gift. I am not here to frighten you away from the operating room entirely. What I am here to do is give you the tools to ask the right questions before you ever get there. Because the problem is not surgery itself. The problem is surgery without the full picture. Surgery without the honest conversation about what a senior body actually goes through when it is put to that kind of test. Here is something that medicine is only beginning to speak about more openly. When you are over 60, over 65, certainly over 70, your body's relationship with surgery is fundamentally different than it was at 40. Not worse, necessarily, but different in ways that demand a different level of scrutiny. General anesthesia alone is a significant event for an older body. The heart has to compensate. The lungs take longer to clear the gases. The kidneys slow their processing of post-operative medications. And the brain, which most people never think to worry about, the brain can become so disoriented by the combination of anesthesia, surgical trauma, and hospital disruption that some patients never fully return to their baseline cognitive function. Doctors call this post-operative cognitive dysfunction. And in patients over 70, studies suggest it occurs far more often than most families are ever told. There is also a medical concept called frailty that does not get nearly enough attention in these pre-surgical conversations. Frailty is not just about looking or feeling old. It is a clinical measurement. It means the body's physiological reserve, its ability to absorb stress and recover from it, has dropped below a certain threshold. And what researchers have found is striking. Nearly 40% of people over the age of 75 show measurable signs of frailty. In people over 85, that number climbs towards 60%. And frail patients, regardless of age on paper, face dramatically different surgical outcomes than non-frail patients of the exact same age. The calendar age is almost beside the point. What matters is what the body can handle. And that question, what can this specific body handle, is one that does not always get answered before the consent form is signed. Now, let us talk about the 5 surgeries. Let us go through them one by one, with the honest information that every senior and every family deserves to have in hand before any decision is made. The first one is open heart surgery in frail or high-risk elderly patients. Specifically, I am talking about coronary artery bypass grafting, which surgeons refer to as CABG. It is one of the most commonly performed major surgeries in America, and for decades it has been performed on older and older patients as the population ages. The concept is not complicated. When the arteries that supply blood to your heart become blocked, surgeons reroute blood flow using a vessel taken from somewhere else in the body. In the right patient, in a 70-year-old who is otherwise healthy and strong, this surgery can add quality years of life. The results can genuinely be remarkable. But here is what the brochure in the cardiology waiting room does not show you. Open heart surgery requires your heart to be stopped, completely. While your heart is stopped, a machine called a cardiopulmonary bypass pump takes over the job of circulating your blood. For a younger, healthier body, the time spent on that machine is difficult but survivable. For a 78-year-old with existing kidney disease, a history of mild cognitive decline, and poorly controlled blood sugar, being on that bypass machine is not just a challenge. It is a simultaneous assault on every major organ system in the body. The kidneys struggle to process the shift in circulation. The brain, deprived of its normal blood flow pattern, can swell or suffer micro-injuries that never fully resolve. The lungs, which were already working harder before the surgery, face a recovery that can stretch into weeks of ventilator dependence. Research published in major cardiovascular journals has found that in frail elderly patients, open heart surgery carries a 30 to 40% risk of major complications. That includes stroke. That includes acute kidney failure requiring dialysis. That includes extended periods of confusion so severe that the patient does not recognize family members for weeks. And perhaps the number that stops people cold when they hear it. In the highest-risk elderly patients, studies have found that up to 15% do not survive the first 30 days after surgery. Not because the surgeon made a mistake, not because the hospital did something wrong, but because the body simply could not absorb what the surgery demanded of it. And here is the part that genuinely changes the conversation for many patients. There is frequently an alternative. A procedure called TAVI, which stands for transcatheter aortic valve implantation, allows certain cardiac interventions to be performed through a catheter, threaded through the blood vessels, without ever stopping the heart or opening the chest. It is less dramatic. It does not feel as definitive as open heart surgery. But for a frail elderly patient, it can deliver comparable outcomes with a fraction of the physiological cost. The recovery is shorter, the trauma is smaller. The risk profile is entirely different, so before anyone you love agrees to open heart surgery, there is one question that should always be asked first. Is there a catheter-based or minimally invasive alternative for my specific condition? That question alone has changed treatment paths for thousands of patients. And the surgeon who gets defensive when you ask it is telling you something important. The second surgery is aggressive spinal fusion in elderly patients with chronic back pain. Back pain is almost a universal experience for people over 65. There is hardly a senior alive who cannot describe the particular misery of waking up with a spine that feels like it has been used for something it was not designed for. And the surgical solution that gets offered with increasing frequency is spinal fusion, sometimes at multiple levels, with hardware bolted into the vertebrae to hold everything in place. For younger patients with specific acute spinal pathology, these surgeries can be life-changing. There is no question about that. But for an elderly patient with the kind of degenerative back pain that comes from decades of living, the evidence tells a far more sobering story. A landmark study published in one of the most respected orthopedic surgery journals found that in patients over 65, complex multi-level spinal fusion carried a complication rate that exceeded 40%. 40%. And these were not minor complications. We are talking about deep surgical site infections, blood clots forming in the legs and traveling to the lungs, hardware failure requiring a second operation, and a condition called adjacent segment disease, where the vertebrae above and below the fused section begin to break down because the mechanical load of the spine has been permanently redistributed onto structures that were not designed to carry it alone. What makes this particularly difficult to accept is what the long-term pain data shows. Study after study comparing elderly patients who had aggressive spinal surgery for degenerative disc disease to patients who were treated with physical therapy, targeted steroid injections, and carefully managed pain protocols found no meaningful difference in long-term pain relief. The patients who went through surgery, who accepted the risk, who spent weeks in recovery, ended up in the same place as the patients who never went under the knife. But one group had to survive a 40% complication rate to get there. The spine is one of the most complex mechanical structures in the human body, and the older that spine is, the more carefully any intervention needs to be weighed. If you or someone you love is being told that surgery is the only option for back pain, please hear this clearly. It is almost certainly not the only option. Ask about physical therapy. Ask about pain management specialists. Ask about minimally invasive decompression procedures that do not involve fusion. Get a second opinion. Get a third one if you need it. The third surgery is something that requires particular sensitivity to discuss because the emotions involved are so powerful and so completely understandable. We are talking about major cancer resections in elderly patients with significant underlying health problems. When someone hears the word cancer, the instinct is immediate and visceral. Cut it out. Remove it. Get it out of the body as fast as possible. And I understand that impulse completely. The word cancer carries a weight that few other words in medicine can match, and the desire to do something, to act, to fight, is one of the most human responses imaginable. But here is something that 2 decades of clinical observation has taught me with absolute certainty. The goal of cancer treatment is not just to remove the tumor. The goal is to give the patient more good years of life. And sometimes, not always, but in a number that is far higher than most people realize, major surgical resection in a frail elderly patient with serious comorbidities does not achieve that goal. It shortens the time, it worsens the quality, and it takes the person not in the direction of living, but in the direction of something much harder. Let me give you a specific example so this does not stay abstract. One of the most complex operations in all of medicine is the Whipple procedure, performed for pancreatic cancer. In this surgery, the surgeon removes the head of the pancreas, a portion of the small intestine, the gallbladder, and part of the bile duct. The surgery itself takes 6 to 10 hours. The recovery, even under the best circumstances, is brutal. In a 50-year-old patient with otherwise good organ function, the Whipple can genuinely extend life in a meaningful way. The risk-to-benefit ratio for the right patient can work in favor of the surgery. But consider an 82-year-old patient with heart disease, chronic kidney impairment, and reduced lung capacity. The cancer is real, the diagnosis is devastating, and the surgical team is technically capable of performing the procedure. They do. The tumor is removed. On paper, the surgery is a success. But the body, already carrying the weight of decades in disease, cannot absorb what the surgery cost. The patient develops post-operative pneumonia. The kidneys begin to shut down. A blood clot forms. Within 3 weeks, the patient is gone. Not from the cancer, from the surgery. This is what medical researchers call futile surgery, and a landmark study from the American College of Surgeons found that nearly 1 in 5 elderly cancer patients who underwent major resection experienced what they called failure to rescue, meaning a surgical complication arose that the weakened body simply could not survive. 1 in 5. That is not a rare edge case. That is a systematic pattern that needs to be part of every conversation between an elderly cancer patient and their oncologist before any surgical consent is signed. This does not mean refusing cancer treatment. It means asking a different set of questions. Ask your oncologist what watchful waiting looks like for your specific cancer type and stage. Ask about radiation. Ask about targeted therapy or immunotherapy. Ask directly and without embarrassment what the realistic survival benefit of surgery is for someone with your exact health profile. And if you do not get a clear, honest answer, find a doctor who will give you one. The fourth surgery is something that sounds far less dramatic than open heart surgery or cancer resection, but it belongs on this list just as much as any of them. We are talking about elective joint replacement in seniors with multiple serious health conditions. Hip replacements and knee replacements are among the most successful surgeries ever developed. I want to say that clearly because it is true. For the right patient, a hip replacement genuinely transforms quality of life. People go from barely being able to shuffle to the kitchen to chasing their grandchildren around a backyard. The improvement can be extraordinary, but the word elective is one that deserves more attention than it usually gets. Elective means planned. It means not an emergency. It means there is time to think, time to prepare, and critically, time to ask whether this is the right moment for this specific body. Because in seniors with 3 or more serious concurrent health conditions, including heart disease, diabetes, obesity, and chronic kidney disease, elective joint replacement carries a significantly elevated risk profile that changes the calculation in ways many patients are never shown. Blood clots are the most dangerous complication. Deep vein thrombosis, where clots form in the veins of the leg, can travel to the lungs and cause a pulmonary embolism that is rapidly fatal. In elderly patients with impaired circulation and reduced mobility during recovery, the risk of clot formation is substantially higher than in younger patients. Add to that the risk of post-operative pneumonia from extended bed rest, the risk of hospital-acquired infections in a body with a compromised immune response, and the risk of anesthesia-related cognitive changes, and the picture becomes far more complicated than the pre-surgical brochure suggests. The important question is not whether a senior should ever have a joint replacement. The important question is whether the body is in the best possible condition to handle one right now, at this specific moment in time. And the answer to that question almost always involves preparation, blood pressure optimization, blood sugar control, weight reduction where possible, cardiovascular conditioning, pulmonary function improvement. Some hospitals are now requiring what they call prehabilitation programs before scheduling elective joint replacement in high-risk elderly patients, and this approach is exactly right. The patient who spends 3 months getting their body as strong as possible before surgery is a fundamentally different surgical candidate than the patient who rolls in on the scheduled date without any preparation at all. If your doctor has recommended elective joint replacement and has not mentioned prehabilitation, I want you to bring it up yourself. Ask what you can do in the weeks and months before surgery to reduce your complication risk. That conversation alone, that active participation in your own surgical preparation, can change your outcome dramatically. The 5th surgery is different from everything we have discussed so far, and I want to explain why it belongs on this list, even though it does not behave the way the others do. The 5th is emergency abdominal surgery. And I know what you are thinking. You cannot choose to avoid an emergency. You cannot opt out of a ruptured appendix or a perforated bowel the way you can decline an elective knee replacement. When the emergency happens, the decision is not really a decision at all. You go to the hospital. You go to the operating room. You do what has to be done. But here is why this belongs in our conversation today. Knowing the risks in advance, before the emergency happens, changes everything about how families make decisions in those terrifying corridor moments when a surgeon is standing there with a clipboard and a grave expression, and there are 12 minutes to decide. Emergency abdominal surgery in patients over 75 carries some of the highest mortality rates of any procedure in all of surgery. In the most severe presentations, we are talking about 30 to 50% mortality within 30 days, not because surgeons are unskilled, not because hospitals are failing their patients, but because a senior body under sudden, catastrophic trauma is fighting on too many fronts simultaneously. The liver, the kidneys, the heart, the lungs, the immune system, they are all hit at once by the combination of the underlying emergency and the surgery required to address it. And the inflammatory response that a younger body can marshal, control, and eventually resolve within days can spiral in an older body into a condition called systemic inflammatory response syndrome, where the body's own defense mechanisms begin attacking its own organs. When that cascade begins, the mortality rate climbs rapidly, and the window for meaningful intervention narrows fast. So what can you actually do with this information about emergency surgery? 2 things, and both of them matter enormously. The first is to take abdominal symptoms in a senior seriously, immediately, and without delay. Persistent abdominal pain, significant unexplained bloating, sudden changes in bowel habits, blood where there should not be blood. These are not things to wait on. These are not things to manage with antacids for 3 weeks and then mention at the next annual checkup. Catching the underlying problem early, before it becomes an emergency, is almost always the difference between a manageable intervention and a life-threatening one. The emergency abdominal surgery that kills is almost always treating something that could have been addressed weeks or months earlier when it was still a smaller problem. The second thing is to have the conversation with your family right now, not in the hospital. Not in the corridor at 2 in the morning when a surgeon you have never met is asking for consent. Now, talk about your wishes. Talk about what quality of life means to you. Talk about what you would and would not want if the situation became extreme. These are not morbid conversations. They are not giving up. They are one of the most loving, responsible things you can do for the people who might one day have to make decisions on your behalf in moments of enormous pressure and grief. Now I want to step back from the 5 surgeries for a moment and talk to you about something that ties all of this together. Because the question I get asked most often, in comments and messages across the senior health education community, is some version of this. How do I know when to say yes and when to ask more questions? And I think that is exactly the right question to be asking. Not, how do I avoid surgery, but how do I make sure I have the full picture before I decide? So, let me give you the framework that I believe every senior and every family member of a senior should carry into every surgical consultation they ever attend. There are 4 questions. 4 questions that, if asked clearly and calmly, will tell you almost everything you need to know about whether you are being presented with the full picture or just one side of it. The first question is, what happens if we do not do this surgery? A good surgeon, an honest surgeon, will give you a straight answer to this question. If the answer is nothing urgent changes in the next 6 to 12 months, then you have time. Time to think, time to seek another opinion, time to explore alternatives, time to optimize your health. The surgeon who gets uncomfortable with this question, who deflects or suggests that waiting is simply not an option without explaining why, is giving you important information about how this conversation is being managed. The second question is there a less invasive alternative to this surgery? Medicine has changed in 15 years in ways that most patients and honestly many non-specialist physicians have not fully absorbed. Robotic-assisted procedures, endoscopic interventions, catheter-based cardiac treatments, laparoscopic approaches that use tiny incisions and camera guidance instead of large surgical openings. What required an open procedure a decade ago very often has a minimally invasive equivalent today. If your surgeon cannot tell you whether a less invasive option exists for your condition, you need to find someone who can. The third question is, what does recovery realistically look like for someone my age with my specific health profile? Not the average patient. Not the 60-year-old who runs marathons and has no other health issues. Your heart, your kidneys, your medications, your living situation. If you live alone, who is going to be there during recovery? If you have diabetes, how will blood sugar management change post-operatively? If your kidneys are already working at reduced capacity, how will they handle the medications that come with surgery? The surgeon who gives you a generic recovery timeline without addressing your specific circumstances is giving you a generic answer, and a generic answer is not good enough when the stakes are this high. And the fourth question, which most people never ask and which may be the most important of all, what is your personal complication rate for this specific procedure in patients over 70? Surgeons track their outcomes. They know their numbers. A confident, honest surgeon will tell you, and their answer should be in line with or better than published national benchmarks. A surgeon who seems surprised by the question, or who becomes evasive, or who tells you that complications are just part of surgery without giving you any actual numbers, is telling you something worth knowing. I want to tell you about a patient. I am going to call her Margaret. She was 74 years old when she was referred to a surgical specialist for a condition that the referring physician described as almost certainly requiring surgery. Margaret was sharp. She was still teaching piano lessons twice a week. She had high blood pressure, managed with medication, and her kidney function was mildly reduced, but stable. She was not frail by any clinical measure, but she was not a young woman either. When she sat down with the surgeon and heard the recommendation, her first response was to ask for time. Not to refuse, not to argue, just to ask for more time to understand what she was agreeing to. The surgeon, she told me later, seemed almost offended by this, as if asking for time was the same as being difficult. She left that appointment without signing anything, found her way to a geriatric specialist who reviewed her full case history, and 2 weeks later sat with a new team who walked her through 3 distinct treatment pathways, surgery being one of them, and gave her the comparative outcomes data for each. She chose the non-surgical pathway, a combination of targeted medication adjustment and a monitored physical rehabilitation program. That was almost 4 years ago. Last year, she sent me a photograph of herself at a piano recital her students had organized in her honor. She was standing, she was smiling, and she looked like someone who had been given exactly the thing every patient deserves: time information, and the freedom to choose. Margaret's story is not exceptional. What was exceptional was her willingness to pause, to push back gently, and to insist on a full picture. Most patients do not do that. Most patients hear the word surgery and assume that the conversation is already over, that the decision has already been made by people who know more than they do. But here's the truth that I want to leave you with before we close today. The surgeon who sits across from you is extraordinarily skilled at one thing: operating. That is their gift. That is their training. That is what they have spent their career perfecting. But the surgeon is not you. They do not know what it feels like to be 73 years old and wonder whether you will recognize your own grandchildren after surgery. They do not know what your morning coffee routine means to you, or how important it is to you to be independent, or what your version of a good life looks like in the years ahead. Only you know those things, and those things matter enormously in a surgical decision. A surgical recommendation is not a verdict. It has never been a verdict. It is the beginning of a conversation. And you are not a passive participant in that conversation. You are the most important voice in the room. You have the right to ask every question, to take every day you need, to request alternatives, to seek second opinions, and to make the decision that is right for your body, your life, and your values. The surgeon holds the knowledge of the procedure, but you hold the choice. And that choice, made with full information and clear eyes and enough time to breathe, is more powerful than any instrument in the operating room. Now, I want to do something a little different before we wrap up today, because the senior health education community is not just a channel. It is a family. Tens of thousands of people, seniors and their loved ones, people who are navigating these exact conversations right now, in waiting rooms and living rooms and hospital hallways all across this country and beyond. And I want to hear from you today specifically. Drop a comment right now and tell me where you are watching from. Tell me your city, your state, wherever you are in the world. I read these comments. The whole team here reads these comments. And when you share where you are, you remind every other person watching that they are not going through this alone. There is someone in Texas who is dealing with the exact same surgical recommendation as someone in Ohio. There is someone in California who has the same questions as someone in Florida. And those connections matter. They remind us that this is not just medical content. This is community. This is people looking out for each other. If this video helped you today, if it gave you even one question you did not have before, one thing you will bring to the next doctor's appointment, one conversation you will have with a parent or a spouse before anything gets signed, then please share it. Share it to your Facebook. Send it to your sister. Text it to a friend who has a mother dealing with a surgical recommendation right now. You do not have to say anything. Just send the link. Because the information in this video is the kind of information that can genuinely change a decision. And a changed decision can change everything that comes after it. And if you are not yet subscribed to Senior Health Education, please do that right now. Every week we bring you exactly this kind of content. Honest, researched, senior-focused health information presented in plain language without the runaround. No jargon, no agenda, just the real picture, delivered with the care and respect that every senior and every family deserves. My name is Dr. Arion. Thank you for being here today. Take care of yourselves, take care of the people you love, and I will see you in the next one.